Welcome to your primary care child health hospital at home education module. During this session, we will do some additional education on the common conditions referred. We'll also look at the primary care specific referral pathways. At the moment, Child Health Hospital at Home accepts primary care referrals of children with a diagnosis of bronchiolitis, wheeze, gastroenteritis and reduced oral intake. We'll also review the hospital at home service and see how this links to primary care, and we will review how to make a safe referral. At the end of this session is a QR code for an assessment. You can take this assessment as many times as you need, and once you achieve a score of 10 out of 14, we will be able to send you a certificate to say you are a Child Health Hospital at Home educated referrer. Bronchiolitis. This is a very common respiratory illness in babies. It can occur from birth to around 2 years old. There's a normal pattern that's important to remember, because if children present outside the normal pattern, we need to be thinking about other differentials. The illness usually starts with snot and cough that sounds like a smoker's cough coming out of a little baby. The first day of cough is thought of as day 1. With the cough you get increased work of breathing and wheeze, and with this increased work of breathing it becomes more difficult to feed, and feeding's decreased and children can get dehydrated. Children will get worse until day 3 or 4 before they improve. They should continue to improve in a linear manner, but they can cough for 8 weeks after an initial infection, and I usually describe this as a cough that annoys the parents more than it annoys the babies who remain well. It's really abnormal to have any temperatures over 39 degrees with bronchiolitis. This is our assessment grid from our bronchiolitis pathway. It's based on the Healthier Together pathway. You assess the child as you normally would, looking at their behaviour, appearance, respiratory symptoms, hydrating symptoms, their temperature. It's also important to think about risk factors for more severe illness. The children in the green category are not suitable for a Child Health Hospital at Home referral because they're too well and they don't need additional support. These are children with respiratory observations in the normal range, not significantly dehydrated, with no additional risk factors. These can be discharged with written advice as you normally would. Similarly, the children in the high risk category need referring to paediatrics. They look unwell, they're significantly desaturated with saturations under 92% or a history of apneas. Now, if they've had a history of apnea, even if their saturations are high, they still need to be seen by paediatrics. These children are significantly dehydrated or having high temperatures. Thinking about their risk factors, they have things like lung disease, cardiac disease, neuromuscular disease, or immunocompromised. All these children need acute treatment in the GP surgery and a referral to paediatrics. The children suitable for this referral are in the moderate risk groups. These are the children you would be considering referring into the hospital, but instead of that, you can call us. These children are tachypneic with borderline saturations, but still above 92. They are taking over half of their feeds, but they're still clinically dehydrated. The children under 12 weeks with a high temperature above 38 need to see paediatrics. We also can be support of children with risk factors. These are children more likely to get unwell. The young ones under 6 weeks, the ex-premies, or the ones that are reattending or have families that are not coping with the illness for whatever reason. We aim to support the children at home that would otherwise go to the Children's Assessment Unit for a period of observation or possibly an admission. This is the advice I give to my patients with bronchiolitis when I discharge them. I describe the normal pattern so that they know when to seek help in the future. I highlight the red flags to them, which is again written on the Healthier Together information leaflet. The care advice of little and often feeds is useful. I do sometimes have to explain that you need to physically make up less feeds in a bottle rather than expect a child to stop feeding. Saline nasal drops might help before a feed, but if they distress the baby more than they help the feeding, they're probably not worth it. At the bottom is the feed calculations that you can keep for your records to know what a normal feed volume and acceptable feed volume is and how to calculate it. Please note, significantly overfed children could be having 50% of feeds, which might actually be a normal feed volume for a child of their size. Next, we move on to gastroenteritis. With a clear history of diarrhea and vomiting, with or without fever, with a contact history, it can be a simple diagnosis to make, but I think it's important to think about the differentials, as children can have diarrhea, vomiting and fever in varying combinations with other significant illnesses. Take a moment to think about the symptoms in the left-hand box and the differentials in the right-hand box. How would you assess with your history and examination to exclude them? Lastly, as part of your history, think about what they have been drinking. If all solid has stopped, children can become hypoglycemic quite quickly, as most of what they drink nowadays is water and sugar-free squash. Gone are the good old 80s, where children were fed sugar-loaded drinks when they were poorly. If you have the ability to measure a blood sugar in clinic, this can help guide treatment. However, if you're concerned and you can't, then the Child Health Hospital at Home team can help with close monitoring and support of these children. This is our assessment grid from our gastroenteritis primary care pathway. The children we want are in the amber column. These are not the mildly dehydrated doing okay children, and they're not the obviously shocked, unwell or profoundly hypoglycemic with a sugar under 2 children. These children are grumpy, not tolerating fluid, or you think the family would struggle to do a fluid challenge. They are mildly dehydrated. They might not have passed urine for up to 12 hours. They're not showing any sign of respiratory infection, but they can be a little bit tachycardic. We're also happy to look after children with additional parent or carer support needs and the high-risk children who are under 3 months. Child Health Hospital at Home can monitor blood sugars at home. We have the capacity to prescribe ondansetron and give that to try and break the vomiting cycle. We can also support parents with fluid challenges and monitor their observations to check that they are improving. We also have the opportunity to do some education at home with these families, so when the siblings inevitably contract the bugs, the parents are more empowered to look after them at home. The advice we give on management and on discharge, when they're well enough to be discharged, is based on our fluid challenge sheet, which is part of your primary care pack. The type of fluids to drink: breast milk, Dioralyte, apple juice and water, or squash and water, providing it is sugary squash. On the fluid challenge chart are volumes to aim for based on weight, and the red flags I highlight to families are not passing urine for over 12 hours, cold edges, floppy and more unwell. I think if you've got a child in the green section who you're sending home, it's important to give them realistic expectations that they're going to continue to vomit and have loose stool, but if they're not having red flags, carry on. Our next pathway is poor oral intake, and this is a cover-all pathway. As children reduce their fluids and get dehydrated with all manner of underlying illnesses, both bacterial and viral. While you might have made a diagnosis of tonsillitis, hand, foot and mouth, chest infection as their medical diagnosis, quite often the symptom that needs most support is getting them to drink and maintain their hydration. We can also support in getting oral antibiotics into children if they have a bacterial infection needing treatment. For treating infection, you have the Healthier Together guidelines as always, but I thought I'd highlight a good set of guidelines which are very simple to read through and will give you some CPD hours additionally. The British Society of Antimicrobial Chemotherapy, or BSAC guidelines, provide guidelines on the common infections listed in the picture. If you are wondering whether a child needs IV treatment or oral treatment, or whether they're high risk or standard risk, these guidelines are incredibly useful. When a child with whatever diagnosis you've made is not eating and drinking, and you need to assess whether or not they'll be suitable for hospital at home, we have our pathway in front of you. First thing to point out is we do have an exclusion criteria on this pathway. We don't support breastfeeding problems at the moment. Also, children who are failing to thrive as their primary diagnosis are not suitable for hospital at home care. And also, we don't support children with eating disorders or suspecting eating disorders, as all these children require higher levels of care, usually as an inpatient or by a specialist service. The assessment for these children is very similar to that of gastroenteritis. We want them dehydrated but not shocked. That is where we can provide the most benefit. Our general advice for infection on discharge is safety netting specifically for the underlying cause, mastoiditis in acute otitis media, quinsy in tonsillitis, the general sepsis advice, again, all through the written Healthier Together leaflets. Specifically, I tend to advise that any fever over 38 for 5 days in a row or 48 hours from starting oral antibiotics need to see a physician again. And all this can be supported with the written information. You also had the fluid challenge sheets that we'll use with the family at home, but feel free to give them to patients you aren't admitting to us as well. Wheeze. This covers children with reversible airway disease with or without infection, not asthma, children with uncontrolled asthma or very established asthma diagnosis, if not being managed by primary care, should be either admitted to paediatrics or reviewed by the asthma specialist nurses. They are significantly higher risk group for becoming acutely unwell or slipping under the radar with a slow unmonitored decline. And the bronchiolitics should be referred along the bronchiolitis pathway. I am aware, however, that there is some unhelpful overlap with children. The bronchiolitis presents from being a newborn. Until 1, it's usually bronchiolitis, not reversible airways disease. But obviously bronchiolitis continue until you're 2, and viral-induced wheeze tend to start from around 1. So you have a year's overlap of children that have some bronchiolitis symptoms and some wheeze symptoms. Likewise with asthma, there's various myths and legends about how old you must be to get an established asthma diagnosis. My perspective is that you can have an asthma diagnosis when you've been alive long enough to have a recognisable pattern that can be identified as asthma. And again, some of our viral-induced wheezes will go on to have asthma, but most won't. At the Child Health Hospital at Home, we are very aware of these overlaps in age, diagnosis and symptoms, and we aim to support as many children as possible to try and avoid CAU admissions. I want to spend a bit of time on why children are different to adults. Their anatomy is different, and that gives them different symptoms. They're obligate nasal breathers for the first 6 months, so having an upper respiratory tract infection can significantly affect their work of breathing and their ability to feed. Their smaller nasopharynx means that inflammation and snot can cause more of a blockage. They have bigger lymphoid tissue and tonsils, so again you get more upper airway obstruction. Their smaller mouth and larger tongue increase the risk of obstruction. This isn't particularly relevant in wheeze, becomes more of a problem when they're having anaesthetics. Their longer floppy epiglottis is more vulnerable to swelling, which hopefully we've prevented in our vaccinated children. Because the cartilages in the trachea are immature, they collapse more when the neck is flexed, but also collapse more when the airway is under pressure, such in croup. They are less able to compensate when their airway is compromised, either from edema, which is mostly from croup, spasm, and trauma. This means they get more upper airway symptoms. Their airways are very poorly designed, and at a young age they are designed to swell. Down in the lungs, the cilia are immature with poor secretion clearance, and they also have more mucus cells, increasing secretions. This is why children get more unwell with inflammatory airway diseases. Children's airways are smaller, so for example, 1 millimetre of swelling would reduce the diameter of a newborn's airway by 50%, as opposed to just 10% in an adult. Also, with smaller airways, the entire system has increased resistance, requiring more effort to breathe. Children use their abdominal muscles to pull down the diaphragm more than adults with a fully developed set of intercostal muscles, so they can tire more quickly. They physically don't have the muscle reserve. And it's this tiring that is so dangerous for children. This is our primary care wheeze pathway. Again, just to review the inclusion and exclusion criteria, we are after children under 5 who meet the clinical criteria below. The reason that we don't want the under 1s or the over 5s is that they probably don't have wheeze. They either have asthma or bronchiolitis. We are trying to avoid the asthmatics with poor control, and any wheezers who's on more than a Becotide inhaler are in a too high risk group to manage at hospital at home currently. The other exclusion criteria, again, trying to pick up the asthmatics, one who's using a blue inhaler regularly when not unwell with infection, has persistent nocturnal cough, wheeze on exertion, or has had admission with wheeze in the last 4 weeks. The children with frequent wheeze, more than every 4 weeks, is more likely to be ongoing poor background asthma control rather than viral-induced wheeze on top of viral-induced wheeze. The children we don't want are either reasonably well saturated with SATs over 94%, no features of severe wheeze, and maybe a little increased work of breathing, and parents very capable of giving them their blue inhaler. We obviously don't want the life-threatening ones, or the children who have saturations below 92%, are too breathless to talk, and are working very hard. These children probably need some burst therapy, which needs to be done in an inpatient setting. The children we can help with most are the ones who are not amber or red. They've often been having salbutamol at home, but not exceeding 10 puffs every 2 hours. Children on 10 puffs every hour, every 90 minutes, again, are in the severe group. We need reasonably well saturated children. We have higher saturation limits for our wheezers than our bronchiolitics, as it's a different pathology, and lower SATs represent a more unwell state. The children with the raised respiratory rates, again, they'll put them in an amber group. We will happily support families with maybe less unwell wheezers, or children you think will decline if the parents are unable to give them their inhalers, or monitor them appropriately. We ask that our wheezers refer before 2 p.m. so we can get at least 1, if not 2, home visits to review them clinically before we go on to our out-of-hours support. As I'm sure you already do, knowing about how to assess for increased work of breathing and be able to give inhaler within proper technique are the 2 core skills parents of wheezy children need to have. There's some good written information leaflets and QR codes on Healthier Together. For your interest, if you weren't aware of this update, this is our new salbutamol weaning regime that has been put together by our tertiary centre in Southampton. Rather than have set intervals for set puffs, it's based much more on the family's assessment of their child. They recommend assessing your child at least every 4 hours. If they don't need a blue inhaler, continue to reassess them. When you're looking at your child, think, are they breathless or wheezy, or do they have increased work of breathing? If the answer is yes, you give 2 puffs and wait 10 minutes to review their response. If they're not improving, you give another 2 puffs, wait another 10 minutes and look at their response. Once you've given up to 10 puffs, if you're still concerned, you need to seek urgent help. If, however, you've gone up to 10 puffs and they look better, you can then reassess them. This allows for less overall salbutamol use and much more patient-led care. This is the setup of our Child Health Hospital at Home service. We are a 10-bedded ward taking patients from the ward, CAU and the emergency departments in Poole and Bournemouth, as well as this primary care pilot. For primary care, we can only provide admission prevention. Unfortunately, we can't go and see the children that you would otherwise follow up at your GP surgery. The children have to be under 16 years old, have a BH postcode, and have a diagnosis within an established care pathway that we've already been through. We take admissions 9 to 5 Monday to Friday, except for wheeze, which must be referred by 2 p.m. And you refer to us via a phone, which is answered a lot more quickly than the admissions line. This flow chart represents the patient's journey. You in primary care identify that they meet the referral criteria, and otherwise you'll be picking up the phone to refer to CAU. So you make a phone call. Is there space on the ward? No. If we can answer that question quickly, then I'm afraid you do have to call admissions, and we will log that referral decline due to capacity in a hope for future funding. If there is bed space, we'll ask you, will this child be referred to CAU? If not, then we're not going to accept that referral. If you say yes, then our nurses will go through their triage document, making sure we get all the demographics, clinical details, and your management plan. If at the end of this clinical discussion we think that the patient is too unwell, we will take their name and details to the Children's Assessment Unit and advise you to send the child there for an inpatient review. If at the end of the clinical discussion we think that the child is actually too well, we'll discuss the possibility of giving them some open access to our virtual ward to make contact if they decline, but we're unlikely to accept this referral. If, however, the child is suitable, we will let you know at the time of the phone call. We'll advise you to give them our information leaflet, write any prescriptions needed, and possibly send them home with a fluid challenge leaflet if appropriate. We will then phone the family, arrange a face-to-face visit, and if they are a respiratory patient, we'll bring out the SATS probe and any monitoring they need. So at the end of the phone call, you will know if your patient has been accepted or not. You will then be able to send the family home from your surgery with the information they need to have a review in their home from the Child Health Hospital at Home team. For your information, this is the triage form that the nurses will be filling in during your referral phone call. They might well be out and about. So it's a paper form that they'll be filling in with pencil before uploading to our clinical system. I've included a copy of this in the primary care pack, as knowing what you can be asked will help aid a smooth referral. This is the final assessment of the learning from this module. You can either scan the QR code and complete it on your phone, or cut and paste the link into Google. It's multiple choice questions, and if you can score a score of 10 out of 14 or higher, we will send you a certificate as an official Child Health Hospital at Home educated referrer. Thank you very much for sitting through this educational module.